Okay, is it 4:15? It is, it's 4:15. So I am going to get started. I'm really delighted to welcome a longtime friend of the Bladder Cancer Advocacy Network, Dr. Trinity Bivalacqua, who is here as a urologist and as a sexual medicine specialist. And I think one of the things that really strikes me so often is a lot of people, when you're diagnosed with bladder cancer, you want to live. This is what you want to do. And sometimes, even though it's on the consent form that are signed, lots of forms, when you have surgery or any kind of treatment, you're stressing out. You may not notice the mouse print that says something about, we're going to change your sexual function. We may take out some parts that you didn't know about. These are all things that you're not worried about at the beginning because you just know you have cancer. And then you sit there after a little while and you say, okay, you saved my life, great. But wait a minute, you took away some of the best parts. And that's where somebody like Dr. Bivalacqua can come in. It's always helpful to have these conversations in advance. Dr. Trinity Bivalacqua is a professor of surgery and oncology at the University of Pennsylvania in the Division of Urology. He graduated from Tulane and really has done a lot to really focus on urologic oncology, prostate, all that other stuff as well. Sexual medicine is a side piece for you that you become a real expert and a leader in. And he was at Johns Hopkins, which is how we began to know Dr. Bivalacqua. Now he moved up here to Pennsylvania. And so we're really delighted to have him present to you. We've got some slides. We were going to have Dr. Daniela Wittmann, who is a therapist from the Michigan area. She was coming in from the University of Michigan area. And unfortunately, she got sick and wasn't able to come. But because Dr. Bivalacqua and Dr. Wittmann work well together, she was very willing to share her slides. So Dr. Bivalacqua is going to talk a little bit about some of the other aspects that go along with it. And we'll have a big question and answer period at the end.
Thank you. Can you put my mic on and then also put Dr. Daniela's slides, if you don't mind? So it's all one presentation. So my name is Trinity Bivalacqua. I'm a urologist. I practice at Penn. But as Stephanie said, like I'm a little bit different than most urologic oncologists because I kind of had a career before I became a urologist, and that was in the field of sexual medicine. Back then, it wasn't called sexual medicine. You know, it was all about impotence. So and impotence implied like men only. And then the field has transitioned a lot more where it's sexual medicine for both men and women. And I met Daniela back, I don't know, probably 20 years ago, and we've worked together, colleagues, not in the same place. And Daniela, unfortunately, is not well, and she wasn't able to travel. So I'm going to give her talk. I am not Daniela. She's this wonderful, soft-spoken, woman that is very knowledgeable. She focuses on, she's a psychotherapist, she has a PhD, and she sees couples, she sees men, women, and it's about sort of relationship and how that intersects with the medical management of sexual dysfunction. So she is a wonderful resource. She's at the University of Michigan. These are her slides. I'm going to talk around them. And I think one thing that we forget as oncologists, surgical oncologists, is that are taking care of bladder cancer, it's mostly men, but women are also get diagnosed with bladder cancer, and the way that we manage women needs to be very different than the way we manage men. And I'll explain to you how I've sort of developed kind of a unique practice as it relates to that. I think this is a slide from work that was done, actually published a couple of years ago now by Jim Cotto, who's in the UK, where he actually looked at patients that had TURs, TURBT for non-muscle invasive bladder cancer, and patients that underwent cystectomy, had different treatments. And it was very clear. So domain score means if your score is high, you have impairments as it relates to male sexual, female sexual problems. That could be erection. That could be dyspareunia, pain with vaginal intercourse. It could be dryness for women. It could be shortening of the vagina secondary to a cystectomy. It could be erectile dysfunction in men. It could be Peyronie's disease, calcifications. And what you see here is that is highly prevalent, especially in patients that underwent a cystectomy. Less prevalent if you had radiotherapy, but still present, okay? The problem is, in our field is that a lot patients express the need to talk to urologists about their sexual dysfunction at baseline as well as after treatment. And the problem is most urologic oncologists, number one, don't have time, and all they're thinking is chemo, radiation, surgery, cancer. We hear it all. I've been hearing it for the last hour or two. But what has to be part of that conversation is like, what is life like with treatment of your cancer? And unfortunately, most providers recognize the importance of it, but don't incorporate it into their clinical practice. And I'll speak more about that in a minute. This is actually Daniela's slide, but it's actually work from one of my trainees that did this work with me. It's actually, we actually asked the question because what we noticed was that women that underwent bladder cancer treatment we felt were suffering because of the lack of education that urologic oncologists had in treating women with bladder cancer. So we asked actually urologic oncologists that were part of the SUO, the Society of Urologic Oncology, about how they counseled women and men prior to cystectomy, okay? And what this slide shows us is that, number one, we're not counseling our patients, both men and women, but we counsel men more than women. And more importantly, we don't ask about the partner. What about your partner? Like, I'll tell a little story. I started my clinical practice in 2009, and I'll never forget, within the first 12 months, a man was diagnosed with bladder cancer, muscle invasive, in his 80s, took out his bladder, and the first question he told me in that first visit was, "Doc, what did you do to me? Like, I can't, me and my wife are no longer able to be together." And it just like, it was like, wait a minute, I'm a sexual medicine specialist and I didn't bring this up. And then I was counseling a woman as to, tell me about, do you have a partner? Yes. Or tell me about, we talk about vaginal intercourse, how you relate to that. And she just started laughing. She goes, "Honey, I don't want anything in my vagina. My partner does not penetrate me." And I was like, okay. So, it became very clear that despite my ability to be a specialist, I was not really talking to my patients the correct way. And that's exactly what our study showed, okay? The thing that's interesting is, only 5% of urologic oncologists felt like it was outside the scope of their practice. They felt like it was important, and it was only 5% were outside the scope of their practice, but they're not doing it. So what's the disconnect here? And I will tell you right now, it's education. So if you don't have a doctor like me that happens to know about both of these, then ask your doctor to get you to the right person. So I've been hearing a lot about Memorial Sloan Kettering because looks like a lot of people here. Like, for example, they have, his name's John Mulhall. John Mulhall is a sexual medicine specialist that sees all of, the surgeons, patients postoperatively, and that's wonderful. But maybe they don't have a famous person at your institution, but I can guarantee you they have someone that you can talk to. So ask, okay? So these are actually from her clinical practice. So once again, this is Daniela, not me. 50-year-old woman with a neobladder who had lost her uterus and ovaries. And I'm going to talk a lot more about that in my talk. So I'll touch base on this in a minute. And then a 58-year-old woman with an ileal conduit who had several revision surgeries. So I'm just going to quote what her patient said. Nobody ever told me that I would go into menopause. It hit me hard. My interest in sex was always low. This made it much worse for my husband and me. Second patient, and this is a 50-year-old. What I'm going to show you in my talk is like, what the hell was that surgeon doing taking out her ovaries? Is what it'd be my point. And I'm sorry, this is no disrespect to my colleagues, but I don't take women's reproductive organs out, period. And I'll show you the data that supports that, okay? Yeah, thank you. 58-year-old woman here. I searched for resources to help with my sexual problems. I found a menopause institute in my area. Very good. That is helpful. I think people were asking about this. They did a 2-hour evaluation and sent me to a physical therapist. It was only then that I learned that a vagina may have various sizes after a cystectomy, and that no matter how much dilating I would do, my husband and I would never be able to have intercourse. So what I'm going to show you later is that we shouldn't be removing the anterior vagina of women. Why? Bladder cancer doesn't invade the anterior vagina, at least in 95% of women, right? So why are we doing that, okay? And I'll show you, and I'll tell you why in a little bit later. These are, what Daniela is pointing out here is that it doesn't matter if you're having a cysto, a TURBT, a radical cystectomy, intravesical therapy, it impacts your sexual life as it relates to potentially, for example, men, erectile dysfunction, but more importantly, psychologically. Your ability to engage with your partner and be able to get outside of that treatment of bladder cancer, right? You're thinking, I have cancer, I'm getting treatment, I don't want to be intimate with my partner, right? So bladder cancer treatment impacts in every aspect, okay? Unfortunately, this is not studied as much in bladder cancer, and there's not as much education as in other cancers, for example, breast cancer, prostate cancer, okay, to compare. As it relates to women, we know from her quotes is that women are impacted after, in particular, radical cystectomy, because it is a dogma that we as urologic oncologists remove the anterior vagina, the uterus, the cervix, and both ovaries. It's dogma, okay? This is what I was taught when I was training, and I was very fortunate to have a gentleman who Stephanie knows and people at Beacon know, you guys might know, his name is Mark Schoenberg, okay? There we go, exactly. Hey, how are you? So Mark was the person that taught me, and he just said, why are we doing this? And we developed techniques to prevent some of the problems that women had as it relates to early menopause. It relates to pelvic floor dysfunction, pelvic organ prolapse. In the case after cystectomy, that's your intestines that are prolapsing, and also shortening of the vagina. As it relates to men, it's just like if any of your family members, colleagues underwent a radical prostatectomy, it's the same thing. You're going to have the same sexual dysfunction after a radical cystoprostatectomy as you would if you just had your prostate removed. Except the problem is because you're older, on average, the average age of someone undergoing a cystectomy for muscle-invasive bladder cancer is in their 70s, whereas for prostate, it's in the early 60s. So the rates of sexual dysfunction after a cystectomy is actually higher because you have more baseline dysfunction. And if you don't talk to a patient about that, you're never going to know how you can manage them postoperatively. So my cystectomy patients, men that I see, that I operate on, we talk about nerve sparing, non-nerve sparing. What are you doing now to help? What's your relationship like with your partner now? And how can we continue that postoperatively? This is actually Daniela and Svetlana, who urologists in New York, have sort of written about ways that we can, this is for us providers, how we can be more engaged with patients, both as it relates to the biology, for example, hormonal dysfunction, sexual dysfunction, pelvic floor dysfunction, Psychologically, the impact on a couple, the impact on how cancer treatment impacts you, relationships with your family, intimacy, partners, as well as sort of social cues. So she put in here religious beliefs. So when I was in Baltimore, I had a lot of men and women from the Middle East that would come. Still do it here at Penn, but not as much. 2 weeks ago, I was counseling a patient who's actually in his mid-40s from the Middle East, and the first thing I talked to him about was, well, listen, tell me about, when you pray, if there is a situation where you have leakage of urine, will that impact your prayer? And it can be, in some religions, they can be criticized if that happens. So you have to talk about diversions where you won't have leakage, for example. So might not be a good candidate for a neobladder because they feel like if they are sitting and praying and they leak urine, then that's a significant problem for them as it relates to their religious beliefs. So these are things that you wouldn't think as a provider. We need to be thinking about that and talking about it. So as it relates to sexual health assessment, so how do we assess patients? Frankly, it's a physical exam. Okay, obvious, that seems goofy, but if as it relates to a man, do you have baseline Peyronie's disease, for example? Do you have penile curvature? Do you have sexual dysfunction? Do you have hypogonadism, a low testosterone? These are all parts that, as a sexual medicine specialist, it's part of what we do on a regular basis, but most urologic oncologists are not thinking about that, okay? And you should be. Talk about the impact, for example, are you depressed? Listen, a lot of antidepressant medications impact your sexual function, right? So this also has to be discussed prior. Talk about your partner, how your partner and you are intimate. There's lots of ways to be intimate that doesn't involve penetrative anything, okay? And a lot of couples, when you actually ask them, they will tell you, yeah, we are not interested in that anymore. We have other ways that we do that. And you say, okay, tell me what you do. And they tell me, and I say, okay, well, this is how this surgery is going to impact that for you. And then obviously there are systemic comorbidities, diabetes, hypertension, hypercholesterol, smoking. By the way, is one of the biggest risk factors for ED in men is smoking. Unfortunately, a lot of bladder cancer patients have a history of smoking and goes along with that. So this is where Daniela is the bomb and really, really amazing. I'm not a sex therapist. I acknowledge the importance of it. But what she does is she sits down and talks about interventions as it relates to all the domains of sexual dysfunction and as it relates to sexual health counseling, and is able to go through that in order to help them. So in an ideal world, if you have a couple that's prior to surgery, prior to radiotherapy, might be a little bit difficult prior to intravesical therapy, but no reason not to do it, is to have a preoperative consultation with a sexual therapist as a couple to discuss how this will impact you. So what I think Daniela's putting in this slide is that you as a patient, when your doc is finished telling you, okay, you're going to get chemo, you're going to get surgery, you're going to get chemosensitizing therapy prior to radiation. We've just outlined that for you. Your next question to them should be, okay, well, what about these other sort of survivor quality of life questions, such as sexual dysfunction, lower urinary tract dysfunction, body image, how will this impact that? And if they say, well, sorry, I'm not able to, kind of speak to that, then you have to say, okay, then get me with someone. So I think our point here is just ask, and then also ask, what are the expectations from you as a surgeon for me? What do you expect is going to happen? Just like if you're going to have a cystectomy and your surgeon's talking about bowel dysfunction, peristoma hernias, urinary tract infections, they should also be talking about the impact on a couple and sexual function. These are a number of resources that are excellent. I can tell you I'm not familiar with the first organization, but the SMSNA, as well as the Society for Sex Therapy and Research, or STAR, is excellent. It's phenomenal. If you are interested in psychotherapy, go to the STAR website. It is amazing. And SMSNA is a good place to learn about management of sexual dysfunction, both in men and women.
So can I just add a quick
Yeah.
comment that on ASECT, if you go back
Yep, no problem.
the American Association of Sexuality Educators, Counselors, and Therapists have a page where you can find a certified sex therapist in your community. You can search by your community
That's great.
and get names. So it's a really useful resource as well, and Danielle is part of that.
This is Daniela's information. I can guarantee you she'd be more than happy to answer questions. I know she would. If you wanted to contact her, hopefully I've done a service to her talk. I am happy to answer questions about this right now, or do you want me just to go do mine?
Well, let's go to do yours,
Okay.
and you guys have a notebook, write your notes down, and then we'll get to questions at the end.
Okay. I'm now going to transition to talk a little bit more about sort of what as a urologist and sexual medicine specialist is thinking or should be thinking as it relates to management of bladder cancer and the impact on sexuality is the title I think we were given. This is just a slide that tells me to talk about. I went into urology because of that guy. His name is Patrick Walsh. He was the person that developed the anatomical radical retropubic prostatectomy, which is the operation that removes the prostate for people with prostate cancer, and he developed the nerve-sparing technique. And he was the guy that taught me how to do this operation. But he also was the guy that described, guess what, a nerve-sparing operation when you remove the prostate and bladder, okay? So for men, and I'm gonna talk about women in a second, for men, there are nerves, they're called the neurovascular bundle, that run right to the side of the prostate. They're running right here. That if we remove them, the signals that send signals to the penis to bring in blood flow are gone. And you will not get an erection. So the goal is to spare those nerves in order for men to get a functional erection, okay? And this was described in the early 90s, and we've come up with a couple of things that have innovated, but in reality, like we're still doing the same thing as we did in the 90s. The only thing we now just do it with a robot versus open. You know, the outcomes are all the same, by the way. You know what I mean? It's irrelevant. So, but if and as it related to bladder cancer, what we've learned is a lot of bladder cancer surgeons are not doing nerve sparing, because that's not what they did in their patients, the people that taught them. So one of the things the first thing I do when I walk into the operating room, and I'm getting ready to do a cystectomy, my residents and trainees will tell you, like, I'm like, okay, nerve sparing, non-nerve sparing, patient potent, not potent. That is my first question. Doesn't matter if a man or a woman, okay? Because honestly, taking out the bladder and the prostate's easy. That's simple. It's not hard. But doing an elegant operation where you're sparing nerves, sparing the sphincter if the patient's getting a neobladder, and sparing the pelvic floor for a woman is actually super important. Taking out the bladder or bladder and prostate is actually not that challenging. So the realities of post-radical cystoprostatectomy surgery for men is the following. We don't have great treatments. They're on demand. They don't fix the problem, okay? They treat it, but it's not a curative effect. So that's the use of PDE5 inhibitors or Viagra, Cialis. Most people report that after a cystectomy that these are ineffective. And we still have not identified corrective interventions that will cure a patient, okay? And you have to discuss with the patient that there is variable recovery of erections. And actually, it could take upwards of 2 to 4 years to see maximal recovery of erections for men, okay? The earliest you are gonna see erectile function recovery in a man is 1 year. It's actually closer to 2, and you can see improvements for upwards of 4. But in reality, at 2 years, that's kind of where you are going to be, okay? The other thing that you have to tell the patient is that, oh, by the way, your erections are going to be, they're not going to be the same. They're less rigid. If you recover erections, they're less rigid, and you may have difficulty with penetrative intercourse if that is how you and your partner are intimate. We do have erectile aids, pills, don't work typically. And we also have the use of intracavernosal injection therapy, which I'll talk about in others. For women, so this is where, for women that undergo a cystectomy, if they undergo what's called an anterior pelvic exoneration, which I'll describe in great detail shortly, which is removal of the anterior vagina, the uterus, ovaries, cervix, and then reconstruction of the vagina, then there is oftentimes shortening of the vagina. And because you're taking the blood supply to the clitoris and to the vaginal introitus, labia, it is oftentimes, you lose the ability to have moisture or lubrication, okay? So if your surgeon is doing that, you will need ways, moisturizers. Listen, I'm a very big fan of estrogen, intravaginal estrogen. You can do it. It's not contraindicated with people with bladder cancer. It's okay. And there is, as she put it here, no contraindications. This is Daniela's slide, by the way. And then we should be offering women pelvic floor physiotherapy, okay? If you're a man undergoing a prostatectomy, that's the first thing that your provider is going to refer you to. So why wouldn't we refer women for the same reason? This is just a picture to remind me that when you do a nerve-sparing operation in men, and if you don't do a good nerve-sparing operation, the penis atrophies, less smooth muscle is there, and it shortens. So a lot of men after a cystectomy will report a shortened penis, shorter, and doesn't have the same ability to have rigidity, okay? And that's because the innervation of those nerves are compromised, okay? So if you've ever seen someone who have a stroke, lose the innervation to their arm, what happens to their arm? It atrophies, right? What do you think is going to happen to the penis? It's an appendage with innervation. If you de-innervate it, remove it, it's going to atrophy, okay? There's a concept called penile rehabilitation, penile rehab. If you go on any, I need to be careful what I say here. If you go on any website in this country, you will see, you hear about penile rehabilitation. So what's the purpose of penile rehabilitation? It's to preserve the erectile tissue. I just told you what happened to it. It's to preserve the erectile tissue, okay? And you can use different drugs, devices to do that, okay? And the purpose is to bring in with quote unquote oxygenated blood to preserve the penile architecture. So the current medications that have been used for penile rehab, I put here, injections, pills, vacuum erection device. There is investigation of things like stem cells, shockwave therapy, PRP, which is called platelet-rich plasma. Nothing I've just showed you in this slide preserves erections in men. Nothing, okay? So when you go online and you read about this, what you've got to understand is that the thing that predicts an erection recovery is not pills, injections, vacuum erection device, shockwave, PRP. It's if your surgeon did a good nerve-sparing operation. That's the case for a cystectomy or for a prostatectomy, okay? For prostate cancer. Prostatectomy for prostate cancer or a cystoprostatectomy for bladder cancer. This is actually work from John Mulhall, I mentioned him earlier, which showed that if you start to do some type of ED pharmacotherapy early, and in this case injections, shortly after the surgery, you have a better chance for that penis to be responsive to nerve regeneration if it ultimately happens, okay? So This slide is here because what I do with my men that I operate on that have couples and are intimate, I start them on injection therapy about 2 to 3 months after surgery. After they are no longer, they've lost their weight, they're now starting to get their GI tract function back, they're actually out of that catabolic state, and they're all like now thinking, well, let me think about something, as it relates to beyond that of cancer. So that's when we start doing injections, at least in my practice. There are 3 trials, I'm not even going to show you the data, that shows that PDE5 inhibitors do not work to preserve erections. They do work to give you an erection, but taking it daily will not improve your ultimate erectile function recovery, okay? So why do I bring that up? Because a lot of people will spend a lot of money on this and when you don't need to. The good news is it's now generic, so you can actually not have to spend so much money. It will not hurt you to take a PDE5 inhibitor every day, but the only thing that predicts erection recovery is nerve sparing. I'm going to move now to women, okay? As I pointed out earlier many times, dogma, we have to take out the reproductive organs and the anterior vagina. So there is a sort of group of urologists, urologic oncologists that are now, we've coined the term reproductive organ sparing radical cystectomy, okay? What that means is the traditional way that we took out the bladder in women was we removed the bladder, the uterus, the ovaries, the fallopian tubes, and we came wide down the pelvic floor and essentially removed the whole anterior compartment of the pelvis. I mean, this is radical surgery. And sometimes, if there are surgeons, many surgeons, that if you have non-muscle invasive bladder cancer that is unresponsive to treatment, you're still getting this radical surgery, which is unnecessary. I will tell you, there are some women, unfortunately, that have cancer that warrants that. I'm not saying that that it doesn't happen, but you have to determine who it's appropriate for and not. It shouldn't just be, by definition, we're going to do this to all women. So what we've now described is where you preserve all of the nerves that are innervating the vagina, innervating the pelvic floor, and innervating the clitoris and labia. And you just remove the bladder. That's it. Reproductive organ sparing radical cystectomy. What this will do, the hope here is that if you had a non-reproductive organ sparing operation, we know that you shorten the vagina, increase pelvic floor prolapse, you lose the neurovascular bundles, same as in men. You have the neurovascular bundle to the clitoris, you remove. So there's going to be sexual dysfunction, pelvic floor prolapse, a bilateral oophorectomy puts you into early menopause or worsening menopause. And when you remove the blood supply to the vagina, you have even worsening vaginal dryness and pain. So why are we doing this? What I do in my practice is I remove the fallopian tubes, because if you were to develop ovarian cancer, it comes from the fallopian tubes, so women get they get a salpingectomy, but not an oophorectomy. This is we've talked about. So I'm now just going to briefly tell you that we have now shown that if you do what I've just described, it's actually safe, and it doesn't compromise oncological control. So, sorry, I want to point out Sunil Patel, who is actually a junior faculty member at Johns Hopkins. He was my fellow and actually took over my practice when I left Hopkins. Sunil, this is one of his interests and worked with me on this. So what he showed, and this is just the take home, is that if we do an organ-sparing operation in patients with T3 and T4 disease, high-stage cancer, sarcomatoid cancers, and that are lymph node positive, if we still did a reproductive organ-sparing surgery, it did not impact their overall survival. It was the same as if we did an anterior pelvic exoneration. So what we've also shown is that if you do have invasion into the reproductive organs, it happens less than 10% of the time, and you can identify that intraoperatively. So when I talk to a woman about a cystectomy, I say, we are going in, we're doing a reproductive organ sparing operation. However, intraoperatively, I may identify something that doesn't allow me to do that. And if I do, then I'm going to still do my best to preserve your anterior vagina. We're not removing your ovaries, ever. But we may need to remove your uterus and cervix or anterior vagina if I find something intraoperatively. Last thing I'm going to talk about, Natasha Gupta, one of my previous residents now at NYU in New York, does health service outcomes research. Also was the primary author of what Daniela had in hers, which is looking at practice patterns of urologic oncologists. We asked the question, I hypothesized that if I asked the urologic oncologist where the nerves were in women that innervate the clitoris, that they wouldn't be able to identify it. And I was wrong. 76% of urologic oncologists got it right. But the problem is they're not doing the operation. So we do nerve sparing in women. I spare the neurovascular bundles just lateral to the bladder, just like I would for a man, to preserve the clitoris orgasm and ability to have less dryness and dyspareunia. I'm going to skip that because we talked about it. So we as providers need to, for both men and women, be able to counsel patients about sexual health, and that should be part of it. And I will tell you, as patients in the room, if your doc can't talk to you about it, then ask them to send you to someone who can. And you know what? There's nothing wrong with that. I don't expect a urologic oncologist to have the same knowledge base as I do, because I just happen to be trained in both of these fields. I think we need to stop thinking about treating women the way we treated women surgically in the 1950s and move into 2024 and consider doing more innovative surgical approaches as I've described. And I will tell you, it's happening, okay? It's happening, but it's slow. And then there's always barriers to counseling both men and women as it relates to sexual health and postoperatively. And those barriers are oftentimes physician-led or even patient-led. So I know it's not easy to talk about. I know it's not an easy conversation to have, but you need to be able to bring it up, especially if it's important for you and your partner. If it's not, then it's not. I can't tell you how many people I talk to and say, let's talk about, what's, tell me about your relationship. Tell me about, how are you intimate? And oftentimes I'll get from a couple, like, what are you talking about? Like, we haven't been intimate in 10 years. And then that conversation ends. But I can't tell you how many times I've spoken with a couples or an individual, and they just like unload. And the entire conversation goes from, to discussing that, which frankly, it's kind of refreshing, and I don't mind it. This is Daniela's slide. I moved it to the end. I think we've heard about this all day, multidisciplinary care. You have cancer care with oncologic specialists, med, rad, urologic oncology, nurse specialists to talk to you about your stomas, your continence after a neobladder, your catheterizing if you have a pouch. It should be, that nurse specialist should also, for example, my nurse specialist, who's my APP, my physician extender, she does the injections. So she's a stoma nurse, and she also does injection therapy for men. So why did I do that? Because do you know how comfortable patients are seeing me, talking to me about their cancer and then their sexual health, and then seeing my nurse who says, let me talk to you about your stoma, your pouch, and your either in a pouch or your neobladder. And oh, by the way, I'm going to do your injections when you're ready, and I'm going to teach you and your partner how to do that. Okay. So I think we have to have that as part of what we do. Sex therapy, which is what Daniela is super important for couples. And I'm going to leave it there. Thank you very much.
So this is a big deal. Again, I mentioned earlier, yes, you saved somebody's life, but sometimes you take away the best parts, and maybe those parts weren't there, so that's a big question. So just a quick show of hands, how many of you as patients remember your physician, your urologist, if you have a bladder removal, or even the medical oncologist, discussing or asking questions about sexual function?
Great.
I gotta say,
That's awesome.
that's not that many though.
Yeah, but I actually expected it to be less. I think it's
Okay,
wonderful.
good, okay. So this is your opportunity. Well, absolutely, because you're in the middle of a crisis. Obviously, when you're having this discussion with your doctor and you don't know anything about bladder cancer because this is all new, and all of a sudden somebody told you this is what you had and you'd never heard of it.
All I was worried about was survival.
Exactly. So that's where you get through that phase. And if you don't have a doctor who's bringing it up front, you get to the other part and you say, well, wait a minute, I'm still here, but you took away some of the good parts. Wait a second. Even for people that don't have a partner, just knowing that your body works still the way that it used to is really impactful. And so we're definitely going to open it up for questions. But if in fact, Dr. Bivalacqua, somebody goes into their doctor and they're saying, oh, well, this is what we're going to have to, here's your options, and they never bring this up, how could you suggest that they bring it up to their doctor to say, well, what about sexual function?
Yeah, I think so as it relates to surgical treatment, I think that's a little easier because you're having a consultation. Like, for example, if you're getting intravesical therapy and that therapy fails you, you are ultimately going to speak to them about cystectomy. Well, when they're talking about side effects from cystectomy, that's a perfect time to bring it up. If you're talking about neoadjuvant chemotherapy, with your urologist, the role of that, and then surgery, and then they start to go into diversion, you just naturally say, you know what, I know diversions and surgery has impact on other parts of my life, including my sexual function. Bring it up. I think as it relates to radiotherapy and bladder preservation, there's less of an effect for a man on erectile dysfunction. It happens, but it happens later, so it's not right away. I think the place where it's harder to talk about is what impact will this have after my TURBT? I'm going to have a TURBT, I'm going to have blood in my urine for 6 weeks, I'm going to go into clot retention, I'm going to have a catheter, I'm going to do all these things. That's where it gets a little bit harder to talk about because we really don't know how long that impacts people's sexual intimacy or sexual function after that, as well as intravesical therapy. That's a gap in our knowledge.
So we can open it up to questions. There's a question from the front. Nick, can you get over here? Thank you. It's a little hard to see with the lights. Yep.
It is so difficult to understand how the organs are sitting in your body because all of the images show it straightforward. If there were, the way you go for an ear exam, they'll show you where the interior ear is. If there was a way to just show the body in its complexity with all of those organs that you're going to go in and take and remove, I think it would be very helpful in terms of facilitating a discussion. But without it, you're looking at these tired diagrams that don't help you understand where's that bladder getting, where those ovaries. So that would be a recommendation.
I agree with you, and you need a young doc that can do like AI or those visual like videos, where you come in and you look at different angles. I think it's a great idea. Yeah, I think it's a great idea.
You can make your little printer of the nerves and,
Yep.
with the,
Doctor's office one time, I don't remember which one it was, but he actually had a model you could put together.
well, I know that I used to be in the urology space before Beacon, and then, I know that they had those same models for prostate where you can remove the prostate physically, the little models. And maybe they don't have as much.
No, not so much.
For the bladder and prostatectomy, or for women.
Yes, for women, we definitely don't have that. For men, a little
Well,
bit
that's
more.
a shame, because I know for women, they have all of those, your reproductive parts are interchangeable on those little models in the gynecology office. I know that. I used to teach childbirth classes.
I think if you saw what's called an FPMRS doc, which the old term is female urologist, urogynecologist is old. It's now female pelvic medicine and reconstructive surgery. In their offices, they have that, but in a urologic oncologist office, no. For women, I mean. For men, yes, it's there. But I agree with you, if there was like a way that you could almost show like a video where you come in, you start, it rotates, it's...
You could begin to facilitate a discussion,
Yeah.
but you could see, oh, you taking out both my ovaries?
Yeah, no, that shouldn't happen.
So obviously, there's a lot that still needs to be done in the education space. We've got a question in the back, and
Richard,
then they'll
let
come
somebody
up.
else talk. Let somebody else talk.
We'll come
I
back to you.
want to ask you if you have familiarity with Reverie that has, no, I have difficulty pronouncing it.
It's okay.
Hyaluronic acid
Acid.
for moisturizing,
Yeah.
vaginal moisturizer.
Yeah. I don't have experience. I'm sorry.
I
cut you
was
off.
going to say earlier, and I didn't have a chance to ask the question, they brought this up as maybe being an irritant and not using it during treatment. I'm a little confused. I've heard you can use it, but I'm not sure, like it wouldn't affect or hurt any, like increasing, getting cancer, but that it might be an irritant and it may not be a good idea to use. I just don't know when.
Yeah, so I don't have any experience in my clinical practice treating women with that. I know it's used in cosmetic surgery. I know it's used as injections, for a lot of dermatology and plastics. I'm not aware of its use post-cystectomy, so I can't really speak to it. In my practice, I encourage a lot more hormonal manipulation.
Right, but on I didn't have a cystectomy. It's just, I can't even pronounce, these words I can't pronounce,
So
but.
if you have something called lichen sclerosis, which is it's a disease where you have contraction, fibrosis, scarring, and that can happen in men, for example, in the glans penis, and it can also happen in women where the vaginal introitus is contracted. I can see it potentially being utilized in that area, but once again, I don't have any clinical experience with it, so I can't speak to it. I'm sorry.
Right.
Okay.
And Dr.
I do-
Gadisapur is going to speak again tomorrow, so if you were referring to Dr. G and Dr. Shapiro,
Yes, I think so.
he'll
I
be
think he
speaking
mentioned it.
tomorrow, so you
Yes.
could bring it up with him tomorrow,
Yeah.
perhaps.
And
If there's
just-
someone here that knows the answer, please answer. I just don't.
Yeah. Well, he's not here now. but
Oh,
he-
okay.
Yeah.
Oh, there you go.
Oh, yeah, you are there. Okay, I couldn't see you.
Oh, he's here.
So do you need a microphone to answer the question?
Yeah, so I think we were talking about that going into the bladder during intravesical therapies to help with,
Oh.
contracted bladder and whatnot. And that's a sort of a separate indication. And so, yeah, we wouldn't recommend doing that during like your induction course or maintenance course with intravesical therapies. But in terms of, vaginal lubrication and things like that, I'm also not aware, but I also agree with you that, estrogen would be our go-to, if that answers your question.
Okay, thank you.
Okay.
Okay. So we have another question over here, and then if you could bring that forward, Nick, that would be great.
Question. I had a radical cystectomy and prostatectomy, and we discussed ahead of time the functional loss, and sort of the function has come back. But what hasn't come back, now that I'm dating after all of that, is orgasm. And is that?
Yeah, I
I've
can
been
speak to
told
that.
it's kind of in my head, and I feel like I'm not crazy, but
No, you're not crazy at all. So after a prostatectomy or a cystoprostatectomy, in your situation, number one, you can still have orgasm. So first thing to know about orgasm and erection, they're two separate physiological events. okay? So, Dr. Walsh, this is a horrible joke, but I will say it. No, I'm not going to say it. There's a joke, but like, so for example, a man can have a non-erect penis, a flaccid penis, and still have an orgasm if you are intimate, aroused, and turned on. So that goes to like, if Daniela was here, she would say, you know, there's lots of ways to be intimate with your partner, which is touching, feeling, the sort of relationship that you have with that other individual. But for men, most men think the only way I can have an orgasm is if I have an erection. But when you have an erection and you're intimate, orgasms after a prostatectomy or cystoprostatectomy they change. They can be more intense. So a lot of men will say, I have an orgasm, but it almost hurts. I have an orgasm and I just don't have the same sensation or feeling. I have an orgasm and I leak urine now, called climacturia. So if you have a neobladder and that you can, when you have orgasm, a lot of men with neobladders have orgasm, leak urine. Climacturia is the term. But understand that an orgasm is more of the psyche, the psychological component to it. So a lot of men that have their prostates or prostate and bladder removed, especially if they start a new relationship, there's lots of things that are going in your mind. You know, I have a new partner, they're not used to potentially being with someone who has my, quote unquote, different, you know, same anatomy, but you know, maybe have a little bit different impairment or how I function. And that's where meeting with a sexual health counselor to talk about your relationship and that intimacy with the other individual will help potentially. But orgasm has nothing to do with erection. And it does change, unfortunately, after a prostatectomy or cystoprostatectomy.
Yeah. And we will do our best. Dr. Wittmann had laryngitis. She's like, I can't talk. There's nothing I can do. So we will wait till she heals, and we will schedule a webinar and send you all a very specific invitation to make sure that you can listen to her talk from her perspective, because she brings that therapist perspective into it and does an amazing job.
She's unbelievable.
Of really covering all of those aspects. So we'll make sure that we have a resource for you following the summit. Okay, let's see, where's the next question? Up, there you go.
So, what I don't understand is the relationship between shrinkage, chemo, loss of testosterone production. Is the chemo kind of does the chemo destroy the ability of the testicles to produce testosterone?
So it depends on the chemo. So cisplatin-based chemotherapy affects spermatogenesis, so ability to make sperm, as well as testicular function. For a young man, for example, with testis cancer that gets platinum, they rebound very easily. Testis cancer patients are usually in their 20s. But men that are older, average age of someone with bladder cancer is in their early 70s. That platinum is going to have a more profound effect on your testicular function. After surgery, doesn't matter if you do nerve sparing or non-nerve sparing, that affects, as I've described, your penile ability for atrophy or whatnot. Radiation therapy affects the pelvic floor, the blood flow to the penis, therefore you get the same issue. So what you have to do as a sort of, if you have symptoms consistent with low testosterone, you replete it. You check and you replete. But that's not going to affect your erection recovery. Once again, testosterone has nothing to do with erections. It has to do with desire, arousal, okay? So those are two separate things. But yes, cancer treatment, both medical as well as surgical, impacts testosterone function, or testicular function, excuse me.
Thank you.
Question over here. Brenda, can you?
So it sounds like all nerve-sparing operations are not created equally. What should patients be asking their urologist to determine if it's, a quality nerve-sparing procedure?
Yeah, great question. So you're absolutely right. Not all nerve-sparing operations are the same. So if you ask your doc about nerve-sparing and they give you a look and they pause, then that probably means that it's not a major part of their practice, for example. If you ask the question and they say, oh yeah, let me tell you about my experience and what we do, and they tell you about outcomes. I'm not saying at 1 year I have a 50% response rate if you're 45 versus 20% if you're 75. That's not what I mean. But they talk in a way that describes erection recovery and how they manage it and what the expectations are. Probably means that they are knowledgeable and are doing a quote unquote nerve sparing operation. So I think you can always ask about techniques for nerve sparing, but in reality, it's experience and how often are you doing nerve sparing? Who do you think is an ideal candidate for nerve sparing? Who is not? Oncologically, there is no reason to not be doing nerve sparing in both men and women. So if they say, for example, well, you have cancer that's there, we have to take it out. No. So I think it's more of, if your urologist is able to have a conversation with you about it, and you feel like they're comfortable talking about it and know, then they probably know what they're doing.
Can I ask a quick question? Is it easier to do a non-nerve sparing because you don't have to stop and be careful?
Are you kidding me? It's like a joke compared to doing nerve sparing.
So we're really asking the physician to rise to the occasion and do a more specific and longer, perhaps, surgical procedure.
Especially in women.
Yeah.
So
you don't want to go to the one who said, oh yeah, I read about that in a journal once. Yeah, I could try that. It's not the one that you want to go to. You want to find somebody that knows what those nerves look like, knows how to avoid them, knows how to keep them safe.
So yeah, that one of the reasons why the adoption of reproductive organ sparing cystectomy in women, it's happening now more than before, is because surgeons, number one, weren't really taught it. And then when they heard about it, they then said, well, wait a minute, that's very different than what I'm used to. That means you got to do all these extra steps. Why am I going to do that? Like, no, I'm okay, I think that is changing tremendously in our field. I think
Is it because we're seeing more women surgeons? More women urologists?
So great
Is that why?
question.
I'm just asking.
Great question. I would like to say that is the case. So there are a couple of female urologic oncologists that are advocates that specifically on the West Coast that are very much supporting it and have done lots of work like myself to show why it's important. I got into it because, as I was saying, like Mark asked me the question, like, can we do this? And we started doing it like in the mid 2000s, and then I just carried it on and studied it for 15 years. And I obviously I was interested because of my history in sexual medicine, right? So, it was important to me. But I think that's changed. The problem, this is the other problem, I need to not be on a soapbox. There's only, 15% of urologic oncologists are female that do bladder cancer? It's like really small. I can almost count on two hands how many, you guys know better than me. How many women urologic oncologists? You got Isla, Cheryl, Seema, Sarah. There are people, but they're not like, it's still a major minority. So I actually don't think it's necessarily because there's more women.
Okay.
Right? Do you guys agree with that?
Yeah, well, I was just wondering if at least attention was being paid from a AUA perspective, again, thinking that there are more women in urology, that they're paying a little bit better attention. That urology does go on both genders. It's not just
Yeah,
a
I
man's
think
doctor.
the SUO is paying attention.
Right. Yeah,
The AUA is paying attention, but there can always be more education.
okay, yeah. that's
There's
the
Armin back
American-
there, I think. Armin,
Yeah,
I can
woohoo.
promise you she
Oh,
does
yeah,
it too.
She's got it. She's
Yeah.
obviously got a voice. But let's first hear from Dr. Handelsman. She had a question or a
Yeah,
comment.
no, just a comment. Sorry, I had to dip out and come back in, but I heard the question about orgasm, and just from the therapist perspective. Now, I would just want to be very clear. I'm not a sex therapist. My understanding of sex therapy is rudimentary. I have enough understanding to direct you towards some books, and if those don't work, then I send you to a sex therapist. Okay. So that being said. Orgasm does happen in the brain just from different stimulations. And so regardless of what your body looks like or is responding to, there are other erogenous zones. I've worked with people that had no sensation from the chest down, who were able to develop an orgasm from, they found a part of their ear that responded well. So there are ways to find alternative means for sexual satisfaction. Something that people don't often think about, and this is where I send people to the sex therapist because it's really complex and detailed, but there are two competing processes that are happening. There's things that are like sex drive, like they are turning you on, right? And then there's things that are happening at the same time that are adding the brakes. And so when we think about orgasm, it's a bi-directional process. So it may not be that it's all just breaks and broken. It's more like we have to tease apart what are your accelerators and how to enhance that, and what are your decelerators and how to work around that. So that's what a sex therapist would do, and hopefully what she would say, but I don't know.
Thank you. Thank
Yeah.
you for saying that.
Thank you so much.
So just co-signing what you were saying,
Yeah,
basically.
so you talk about the accelerator and the brake. So one thing that I have a lot of discussion with a lot of men in my practice that have conduits, right? So, we talk about, well, maybe you're not comfortable having, being intimate and have sexual relations with your partner without your shirt on, because you look down and you're seeing an appliance, and maybe that could be prohibiting that, it could be a break for you, right? So we talk about things, well, maybe you wear a shirt, okay, while you're having, whatever it may be. Other men are like, nope, I'm good, I mean, it's... and then, we haven't talked about this, but I will bring it up. And I think this is important, and I'm not in any way pushing surgery on men, but we always have placement of inflatable penile prosthesis, right? We can always place a prosthesis that will give you a rigid erection that will allow you to have penetrative intercourse with your partner if that's what you want. Doesn't change your sensation, still allows you to have orgasm, and you just have to, all I will say is whoever you see about that, so I place penile, I would say probably 80% of my practice is doing prostheses nowadays is in people that have had a neophallus because they lost their penis or weren't born with one, had a cystectomy, have a conduit, have had a colostomy. So you have to go to someone that knows how to put in a prosthesis with people that have stomas and have unusual things that have happened to their pelvis. So just make sure you pick the right person. But yes, there's penile prostheses that will provide it. So if your erections haven't recovered, you should be talking to your urologist about that. And if they don't have experience with bladder cancer patients with a stoma or with a neobladder or with a pouch or whatever, ask them to refer you to somebody who does.
So Bernadette, can you bring the mic over? Dr. Smith, do you have anything to add? We have tomorrow's speaker,
Armin, I didn't know
Dr.
you were
Armin
here,
Smith,
sorry.
standing on the sides over there. Oh, go ahead and ask your question first, Angie.
I just had a
Yeah.
comment. This is great. I love it all. And my husband and I both are cancer survivors. Thank God we didn't have radical cystectomies, both of us, and then have lots of those issues. But I know this is patient advocacy and all that Beacon does. And I know previously there's been like questionnaires trying to get the word out to the urologist. I mean, all of us here know about the Beacon site. All of us here are here listening to you speak. But we're thinking about all those patients that are walking into their community urology office with a cancer diagnosis. We need to get the word out to all of those people to ask these questions. We need to get the word out with something, whether it's a form, whether it's pamphlets, whatever it is, for us to know to ask those questions in the very beginning, instead of like a lot of us, it's already passed, you know, we've already had that surgery, let's say, you know. But so I love this, but I just want to see, we got to figure out how to get it to the community urologists that are seeing us firsthand.
Yeah, I mean, thank you for that comment. That's where I think we in the United States do a really poor job, where I personally believe, and listen, I'm very biased. I think there has to be like quote unquote centers of excellence, and I think bladder cancer care, in particular, major surgery, or for example, you get BCG and it fails you and you have a recurrence. I think these are patients that need to be referred to. It doesn't matter if it's a lug pug with great expertise in bladder cancer or an academic center. That's where you need these referrals to these, you know, places that have this next level care. Unfortunately, that doesn't happen in the United States because of our health system. You know, and it's a bigger problem than anything anybody in this room is going to fix today. But I think you're absolutely right. It's education, and I think Beacon does a phenomenal job of that. It's just not enough.
So Dr. Smith, we will formally introduce you tomorrow, but you know, on this topic, if you've heard the conversation, do you have any comments?
So I literally like walked in as you were talking about women in urologic oncology. I must have felt something.
Yeah,
so
I
just
know.
walked in here and missed like majority of what was said. But I'm picking up, you know, so some things, you know, there are a lot more women in urologic oncology now than were like 10 years ago when I just started. Like maybe when I started, it was maybe like 10, 15 people. And now there are a lot more. So it's getting better and better. And I think that's going to translate into more kind of gender kind of sensitive care for patients with bladder cancer. And I think, you know, to speak about the female sexuality after, you know, bladder cancer treatments and things like that, and, you know, I think female sexuality is a little bit of a black box and, you know, understudied. And we as urologists, when we get through residency, we're very familiar with the male sexual inventory questionnaire, SHIM, but I am yet to see a urology office that has like a female sexual FSFI score, you know, to kind of evaluate this more objectively. So I think, you know, disseminating information is one of it. Getting more research in this area is going to help, and I think we have a lot more to do and a lot more to learn to make things better for our patients.
Yeah, so Armin brings up an important point. In men, there's lots of studies that look at outcomes with a validated questionnaire, with rigorous endpoints, you name it. Until recently, that didn't exist for female women, women that have bladder cancer that underwent surgery, for example. But we now have that data because there was a prospective, you know, essentially it wasn't a trial, but a prospective study that had multi-center where we were doing the surgeries I described as well as the old surgery, and we now have outcomes, and that will be coming out very soon. So we're learning more. We're doing better. We're just not there completely yet.
Thank you. We have one more.
Okay, a few more questions. We still have about 7 minutes.
There we go. It's on.
Well, thank you, doctor. I have a question about robotic versus open surgery. When I had my cystectomy, I was offered either one. My surgeon's well-versed in both. The difference was 4 hours under anesthesia because robotic is slower. So my question about nerve-sparing surgery is whether this is necessarily robotic or if it can be done without too many problems as open surgery, perhaps sparing patients additional hours under anesthesia. Thank you.
So disclaimer, 90+% of my surgeries are done open, not robotic. I used to do robotic surgery and stopped because I realized the outcomes were no better. And I will tell you for a fact, it is more challenging in my hands, maybe for other people they don't agree, but unfortunately I've done over 1,000 cystectomies in my career, so I've done a lot, I have good experience. It's too many, okay? My outcomes were, as related to functional recovery, I felt were inferior to the open approach. So if I have a young woman, and young for me, definition of young is 60s, 70s, okay? Because my practice, the majority of the people in my practice are in their 80s and 90s these days. You know, if I want to give them best functional recovery in my hands, I do it open. If a patient asks me to do their operation robotically, I have no problem doing it robotically. And I'm happy to do that because the outcomes are not better or worse. They're great. The outcomes, it's not great, excuse me, outcomes are horrible. The outcomes are the same. What I don't like about, and what I think we have to be careful is, a lot of pure robotic surgeons do not do reproductive organ sparing operations in women because it's frankly a lot harder to do that operation with the robot. It's easier to get into the vagina and just clunk, and it comes out, and then I've heard surgeons say, well, the vagina's open, I get to extract the specimen, and then there's less incisions. You know, I didn't show it to you, but the outcomes that I showed you from Jim Cotto in the UK from the ERTC trials, no one cares about incisions. You know, and he showed that in that study. So I think that that's an excuse for some people. I'm a robotic surgeon. I do all of my operations, kidneys, prostates, robotically. The only operation I don't do robotically is cystectomy because the outcomes are not better. So, but that's in my hands. Maybe your surgeon is better than me robotically and has better outcomes. But in my hands, if you are going to get an orthotopic neobladder, nerve sparing, I'm doing that operation open unless you beg me to do it robotically.
Very quick question. Does insurance cover the nerve sparing?
They don't know. It's all coded the same.
Fantastic. That's good.
Nick, we got another question up front here.
Yeah, it's funny. I've had a string of, like the last, so I do 2 cystectomies every Monday. That's like my Monday is 2 cystectomies. And in the last like month, I've been doing one of the 2 has been robotic because patients, it's so funny, in Baltimore, no one cared if I did it open or robot. No one even like asked. But here in Philly, people ask, they're like, it has to be done robotically. And I'm like, okay, it's fine, I'll do it. But, you know, so it's really patient driven, you know, for me personally.
Is there any difference in terms of healing or efficacy of cystectomy for women if there's vaginal sparing?
Yeah, it is. So unfortunately, when the anterior vagina is removed and the anterior vagina is reconstructed or essentially sewn back together, those suture lines where we sew it together, doesn't matter if you do it robotically or open, it loosens, and then a lot of women will drain peritoneal fluid from their vagina for 6-8 weeks sometimes, just like men drain your peritoneal fluid from their penis. How many men that have undergone a cystectomy with a conduit will say, I've got blood and peritoneal fluid for a month? For women, it's longer, and when you reconstruct and you remove like especially if you injure the nerve supply and the nerves to the pelvic floor, then you have more local vaginal symptoms. So problems with mucus production, you'll get drainage, you'll get a lot of that. So for me, I don't like that for my patients, and I can tell you over the years, I've just learned that that, you know, if you do a vaginal sparing, you get a lot less of that. You still get it, but a lot less.
Okay, Karen, you might be the last question because we're right at 5:30.
Can you tell me who? Can you tell me who does the work on the West Coast, the Centers for Excellence, and who
Yeah,
you-
sure. I'd be happy to share that with you.
Okay. Later.
Yeah. I mean, listen. You have to tell me where you live, and if you tell me where
San
you
Diego.
live, I'll tell
She's
you.
in San Diego.
Oh, you're in San Diego. Okay, no problem. I can do that.
Yeah. Well, we have come to the conclusion. Thank you so much, Dr. Bivalacqua. I hope that, you know, everybody will go back and talk to their physicians and, you know, be more comfortable bringing up the issue of sexual function. We have happy hour now and then dinner. I hope you will join us. We'd love for you to join us for happy hour. Dinner is all great. I really appreciate it, and we will definitely get in touch with Dr. Wittmann and see when she feels better if we can get her to do a webinar. So thank you all so much. We have happy hour, we have dinner tonight. This is your opportunity to make some new friends, get together with folks, and we'll see you in the morning as well. We start with our patient voice panel, okay? Thank you so much. Wonderful.